3-year-old girl presents with isosexual precocious puberty, gelastic seizures, and a soft tissue density round mass at the region of the hypothalamus on Mr. Brain. No contrast enhancement is evident and the lesion returns signal similar to gray matter on all sequences. What is the diagnosis? A. Pituitary macroadenoma. B. Cyst of the Rath's pouch. C. Hamartoma of tuber cinereum. D. Meningioma. E. Aneurysm of ACA. Most patients present in the first or second decade of life, with boys being more commonly affected than girls. Girls. These lesions have been divided into parahypothalamic hamartomas and intrahypothalamic hamartomas. Parahypothalamic hamartomas are pedunculated masses attached to the floor of the hypothalamus. These lesions seem more likely to be associated with precocious puberty than with gelastic seizures. Intrahypothalamic hamartomas are sessile masses with a broad attachment to the hypothalamus. They lie within the hypothalamus and may distort the contour of the third ventricle. In addition, they seem to be associated more often with gelastic seizures than with precocious puberty. At MR imaging, they are seen as well-defined pedunculated or sessile lesions at the tuber cinereum, and are isointense or mildly hypointense on T1, weighted images, and ISO, to hyperintense on T2, weighted images, with no contrast enhancement or calcification. The absence of any long-term change in the size, shape or signal intensity of the lesion strongly supports the diagnosis of hypothalamic hamartoma. Salim S.N. A 60-year-old man presents with a long-standing painless mass in his left thigh, which has been increasing in size over recent months. Plain film demonstrates a soft tissue mass with poorly defined curvilinear calcification and cortical erosion of the underlying femur. MRI demonstrates an inhomogeneous, poorly defined lesion that is isointense to muscle on T1W images and hyperintense on T2W images. Which of the following is the most likely diagnosis? A. Liposarcoma. B. Pleomorphic undifferentiated sarcoma. C. Rhabdomyosarcoma. D. Lipoma. E. Osteomyelitis. SN, ETAL lesions of the hypothalamus, MR imaging diagnostic features. Radiographics. 2007, 27, for 1087-108. 82, B. Pleomorphic undifferentiated sarcoma. Pleomorphic undifferentiated sarcoma was previously known as malignant fibrous histiocytoma. Malignant fibrous histiocytoma is the most common soft tissue sarcoma of late adult life. It typically presents as a painless, soft tissue mass, which is often located in the thigh and measures 5-10 cm. X-ray demonstrates a non-specific soft tissue mass with calcification/ossification detected in 5%-20% of patients. Secondary osseous involvement is uncommon. It can be identified as periosteal reaction, cortical erosion, and pathological fracture. CT findings include a non-specific, large, lobulated, soft tissue mass of predominantly muscle density with nodular and peripheral enhancement of solid portions. There are often central areas of low attenuation, which represent myxoid change, old hemorrhage or necrosis. The lesion does not contain fat. MRI typically reveals an intramuscular mass with heterogeneous signal intensity on all pulse sequences. As with other soft tissue neoplasms, the signal intensity pattern is nonspecific, usually low to intermediate on T1, weighted images and intermediate to high on T2, weighted images. Regions of prominent fibrous tissue, high collagen content, may demonstrate low signal intensity on both T1, weighted and T2, weighted images, and calcification may present as foci of low signal on both T1, weighted and T2, weighted sequences. Sequences. Monaster BJ, ETAL musculoskeletal imaging, the requisites. Maryland Heights, M.O., Mosby Incorporated, 2002. Osteomyelitis. 83, a 77-year-old woman is sent for a staging scan following a diagnosis of melanoma. All are true for melanoma involving the abdomen, except A. The small bowel is the most common site of gastrointestinal tract involvement by melanoma. B. Metastatic disease to the liver is always calcified. C. Omental and peritoneal deposits occur early in disease. D. Large bowel lesions are uncommon. E. Mesenteric involvement could mimic lymphoma. 83. B. Metastatic disease to the liver is always calcified. The small bowel is the most common site of the gastrointestinal tract involved by melanoma. Appearance can be indistinguishable from that of primary or metastatic adenocarcinoma, lymphoma, or other metastasis. Tumor masses may occur as infiltrating lesions with or without ulceration. Mesenteric involvement by melanoma can mimic lymphoma. Involvement of the large bowel is uncommon but can occur as large ulcerating lesions. Lesions in the liver can be single or multiple and may be partly calcified. Larger lesions are often necrotic. Fishman E.K. Melanoma in the chest, abdomen. Lymphoma. Lymphoma. 84. All the following statements regarding testicular tumor are correct, except A. Testicular lymphoma commonly involves the epididymis and spermatic cord. B. Testicular microlithiasis is associated with alveolar microlithiasis. C. Sertoli cell tumor is associated with Peutz-Jeghers syndrome. D. Primary extragonadal germ cell tumors commonly affect the testes. E. The testis is a common site of leukemia recurrence. Chapter 5. Abdomen and musculoskeletal system. Radiographics. 1990, 10:6-0320. 84. D. Primary extragonadal germ cell tumors commonly affect the testes. Lymphoma can occur in the testis in one of three ways: as the primary site, as the initial manifestation of occult disease, or as the site of recurrence. It is the most common bilateral tumor, and epididymis and spermatic cord are commonly involved. Primary leukemia of the testis is rare. However, the testis is a common site of leukemia recurrence in children. Testicular microlithiasis is an uncommon condition, but several associations are known, including cryptorchidism, infertility, Klinefelter syndrome, Down syndrome, atrophy, alveolar microlithiasis, and testicular carcinoma. There is a calcifying subgroup of Sertoli cell tumors that can be multiple. 5. Test paper 3, 85, an 18-month-old child is suspected of having sustained non-accidental head injury, NAHI. He has a CT scan on admission, which was normal but has ongoing focal neurology. Which one of the following is the most appropriate next step? A. Repeat non-contrast CT of head. B. Repeat CT of head with contrast. C. MRI of cervical spine. D. MRI of head with T2*G, and DWI-E, MRI head with gadolinium. Multiple and bilateral with large areas of calcification. Calcification and is known to be associated with Peutz-Jeghers syndrome and Carney syndrome. Primary germ cell tumors can occur outside the gonads and should be differentiated from regressed germ cell tumors with metastasis. Primary extragonadal germ cell tumors occur in extratesticular locations like the retroperitoneum, mediastinum, sacrococcygeal area, and pineal gland. Regressed germ cell tumor may present with widespread metastases even though the primary tumor has involuted. US plays a vital role in the search for the primary regressed tumor. They have a variable appearance, are generally small, and can be hypoechoic, hyperechoic, or merely an area of focal calcification. Woodward P.J., ETAL. From the archives of the AFIP, Tumors and Tumor-like Lesions of the Testis, Radiologic Pathologic Correlation. Radiographics. 2002, 22, 180. 189-16. 85, D. MRI of head with T2*G, and DWI. When a child is admitted acutely with suspected NAHI, the primary neuroimaging performed on day 1 is non-contrast cord of the brain. This has the advantage over MRI in the acute setting of being fast to acquire in a potentially unstable patient, and is highly sensitive to hyperacute blood. The main aim at this stage is to diagnose/exclude any acute hemorrhage amenable to neurosurgical treatment. If the child has ongoing neurological signs/symptoms, or an abnormal initial CT brain, then an MRI should be performed. This is normally done at 3-5 days. Contrast is not necessary, but DWI for ischemia, and T2*GE or similar sequence, for the detection of blood products, should be considered. If there is abnormal imaging during the patient's acute admission or persistent neurological signs or symptoms, then a repeat MRI brain at 3-6 months should be considered. If the first presentation is non-acute, then MRI is the appropriate initial imaging modality. Royal Colleges of Radiologists and Pediatrics and Child Health. Standards for Radiological Investigation of Suspected Non-Accidental Injury. Royal Colleges of Radiologists and Pediatrics and Child Health, 2008. www.rc.ac.uk/docs/radiology/pdf/rcpch_rcr_final.pdf, accessed on February 16, 2017. 86. Comet tail sign is specific for distal ureteric. 86. A 53-year-old man with painful hematuria and left loin to groin pain progressing over the last 5 days has been scheduled for a CT urogram to look for a left ureteric calculus. Regarding CT evaluation of ureteric calculi, all of the following are true, except A. Indenover stones are often missed on CT. B. Ureteric stones tend to lodge at PUJ, VUJ, and where the ureter crosses the iliac vessels. C. Periureteric stranding is a secondary sign of ureteric obstruction. D. Stones less than 10 mm can pass spontaneously without intervention. E. Comet tail sign is specific for distal ureteric calculus. 87. A middle-aged woman presents to casualty. Ureteric calculus. Most textbooks of anatomy describe the ureter as having 3 Anatomical narrowest points. These are the pelviureteric junction, PUJ, the point where the ureter crosses anterior to the iliac vessels, and the ureterovesical junction, UVJ. However, contrary to previous teaching, there is. Chapter 6. Test Paper 3, Answers. 166. Debate whether these are the most common places for stones to be lodged. Indenover stones have soft tissue attenuation, 1530 Hu, and are likely to be missed at unenhanced CT. However, renal colic in a patient receiving Indenover therapy for HIV infection, along with the presence of obstructive features at CT, usually helps clinch the diagnosis. The most reliable signs of ureteric obstruction include hydroureter, hydronephrosis, paranephric stranding, periureteral edema, and unilateral renal enlargement. Stones less than 5 mm have a 68% chance of passing spontaneously, and stones between 5 and 10 mm have a 47% chance. The soft tissue rim sign consists of a halo of soft tissue attenuation around a calcific focus, and is very specific for ureteric calculi. The comet tail sign is created by an eccentric tapering soft tissue area adjacent to a phlebolith. These two signs are used to differentiate ureteric and pelvic calcification. Cambaticone AR, ETAL. New and evolving concepts in the imaging and management of urolithiasis, urologist's perspective. Radiographics. Casualty with progressive increase in right hip pain and inability to weight bear. Plain films performed in the A&E department reveal a stress fracture involving the neck of the femur, which accounts for her clinical state. However, there is no history of acute trauma. Which one of the following statements concerning fatigue and insufficiency fractures is true? A. A fatigue fracture is due to abnormal stress on an abnormal bone. B. A fatigue fracture is due to normal stress on a normal bone. C. An insufficiency fracture is due to abnormal stress on a normal bone. D. A fatigue fracture is due to abnormal stress on a normal bone. E. The cause of these two fractures is essentially the same. 88. All the following are true of Creutzfeldt-Jakob disease, except A. No contrast enhancement. Radiographics. 2010, 30-360323. 87, D. A fatigue fracture is due to abnormal stress on a normal bone. A fatigue fracture occurs from excessive and repeated stress on normal bone. An insufficiency fracture occurs from normal physiological stresses on abnormal bone. Both entities are part of the larger group of fractures known as stress fractures, which is the term used to describe fractures occurring from a mismatch of bone strength and chronic mechanical stress. Monster B.J. ETAL. The requisites, MSK Imaging, 4th ed. Philadelphia, PA, Mosby, 2013:9. 8. Enhancement B. No white matter involvement. C. Bilateral high T2 signal change in the caudate and putamen. D. Associated with dementia and myoclonus. E. Self-limiting disease of good prognosis. 88. E. Self-limiting disease of good prognosis. Creutzfeldt-Jakob disease, CJD, a fatal neurodegenerative disorder, is diagnosed by the detection of an accumulation of an abnormal form of the human prion protein PRPSC in the brain. It is characterized by rapidly progressive dementia, cerebral atrophy, myoclonus, and death. The T2-weighted MRI of SCJD, sporadic CJD, patients often shows high signal in the head of the caudate nucleus and in the putamen as compared with the thalamus and the cerebral cortex. Hyperintense signal changes can also occur in the thalamus, but in SCJD they are usually less prominent than those in the putamen or the caudate nucleus. In addition, there is high signal in the cerebral cortex in some cases. With the introduction of the new sequences FLAIR and DWI, these signal changes are more easily identified. Patients with the new variant of CJD, VCJD, show bilateral increased signal on MRI in the pulvinar thalami relative to the gray matter of other basal ganglia and the cerebral cortex. There is currently no curative treatment and the disease is invariably fatal. A 42-year-old woman with right upper abdominal pain and worsening LFTs is referred for in U.S. The scan shows heterogeneous echotexture to the liver without any definite focal lesions and no Doppler flow within the hepatic veins. A dual-phase CT liver shows hepatomegaly and a hyperenhancement of the caudate lobe with hypoenhancement to the rest of the liver. Ascites is present. A diagnosis of Budd-Chiari syndrome is made. All of the following are predisposing factors, except A, pregnancy. B, antiphospholipid syndrome. C, alcohol abuse. D, membranous web-like obstruction of HV or IVC. E, tumor invasion of the hepatic veins. 90. A 10-year-old boy with history of Down syndrome, recurrent chest infection and dyspnea on exertion. Presence to the pediatrician. Fatal. Champa H.J., ETAL MRI in the diagnosis of sporadic Creutzfeldt-Jakob disease, a study on interobserver agreement. Brain. 2005, 128, PT 9 2026 33. 89. C. Alcohol abuse in approximately 75% of patients, a hematologic abnormality, or a cause of thrombotic diathesis, can be identified that predisposes the patient to the occurrence of Budd-Chiari syndrome. The presence of multiple causes in the same patient has been reported. Hematologic diseases, especially myeloproliferative disorders, are the most common cause, and it has been suggested that patients with idiopathic Budd-Chiari syndrome may have an underlying myeloproliferative disorder. Causes of thrombotic diathesis that have been associated with Budd-Chiari syndrome include paroxysmal nocturnal hemoglobinuria, antiphospholipid syndrome, inherited deficiencies of proteins C and S and antithrombin 3, factor V Leiden mutation, prothrombin gene mutation, methylene tetrahydrofolate reductase mutation, use of oral contraceptives, pregnancy, and immediate postpartum status. Metastatic invasion of the hepatic vein, IVC, or right atrium and primary tumor occurrence in the kidney, liver, adrenal gland, IVC, or heart are less frequent causes of Budd-Chiari syndrome. Membranous web-like obstruction of the hepatic vein, or IVC, is a more prevalent cause of. Chapter 6. Test Paper 3, Answers. 167. Hepatic venous outflow obstruction in the Asian population. Membranous webs of the hepatic vein, or IVC, may be congenital, or represent sequelae of thrombosis. Cura M. Diagnostic and Interventional Radiology for Budd-Chiari syndrome. Radiographics. 2000. Pediatrician. Chest X-ray shows mild cardiomegaly and prominent pulmonary venous markings. What is the most likely diagnosis? A. Hypertrophic cardiomyopathy. B. Ostium primum ASD. Chapter 5. Test Paper 3, Questions. 134. C. Ostium secundum ASDD, VSDE, PDA. 2009, 29:66981. 90. B. Ostium primum ASD. Ostium primum defects are often seen in Down syndrome and are part of endocardial cushion defects, which also include atrioventricular canal defects, ASD, and VSD, and abnormal AV valves. Most children with small defects are asymptomatic. Those with larger defects are predisposed to recurrent chest infection and heart failure. Ostium secundum type ASD are well tolerated, and symptoms and complications usually only present in the third decade or later. VSD can be asymptomatic or present at various age with recurrent chest infection or heart failure and cyanosis at a later stage subject to progressive pulmonary hypertension. HOCM shows cardiomegaly without plethoric lungs. HOCM presents with tiredness, fatigability, and is a recognized cause of sudden death. Tasker RC. '91, a 10-year-old boy undergoes a contrast-enhanced CT abdomen following blunt abdominal trauma. Anaphylactic shock is suspected. What is the treatment? A. 0.5 milliliters of 1:1000 IM adrenaline. B. 0.5 milliliters of 1:10,000 IM adrenaline. C. 0.15 milliliters of 1:1000 IM adrenaline. D. 0.3 milliliters of 1:1000 IM adrenaline. E. 0.3 milliliters of 1:1000 for adrenaline. 92. A middle-aged woman with a history of right-sided breast cancer underwent adjuvant radiotherapy following surgery several years ago. She has been symptom-free with no features to suggest local recurrence. Over the last few weeks, she has developed worsening right-sided chest pain. Chest radiograph shows a partially destroyed right rib. Rib with a large eccentric soft tissue component. Which one of the following is the most likely histology of the lesion? A. Osteosarcoma. B. Chondrosarcoma. C. Ewing sarcoma. D. Angiosarcoma. E. RC, ETAL Oxford Handbook of Pediatrics. Oxford, Oxford University Press, 2008. 91. D. 0.3 milliliters of 1:1000 IM adrenaline IM dose adults 0.5 milligrams IM equals 500 micrograms equals 0.5 milliliters of 1:1000 adrenaline. Adrenaline IM dose children greater than 12 years, 500 micrograms IM, 0.5 milliliters, i.e., same as adult dose, 300 micrograms, 0.3 milliliters, if child is small or prepubertal, 6-12 years, 300 micrograms IM, 0.3 milliliters, greater than 6 months 6 years, 150 micrograms IM, 0.15 milliliters, 6 months, 150 micrograms IM, 0.15 milliliters. Emergency treatment of anaphylactic reactions, guidelines for healthcare providers. Working Group of the Resuscitation Council, UK, 2008:22. 92. A. Osteosarcoma. The most common radiation-induced sarcoma is pleomorphic undifferentiated sarcoma, previously described as malignant fibrous histiocytoma, which is a soft tissue sarcoma, followed by osteosarcoma, and lastly by fibrosarcoma. In this case, the pathology is centered on the bone, making osteosarcoma the most probable diagnosis. Dannert W., Radiology Review Manual, 6th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2007:144. E. Fibrosarcoma. 93. A 60-year-old man with sepsis and moderate left hydronephrosis secondary to an obstructing left midureteric calculus has been referred to the interventional team for a percutaneous nephrostomy. All of the following statements regarding percutaneous nephrostomy are true, except A. The brodal bloodless zone lies just anterior to the lateral convex border of the kidney. B. The posterior calyx of the upper/middle collecting system is best for ureteral negotiation. C. Large bore drains are used in procedures complicated by gross hematuria. D. Nephrostomogram and overdistension can cause bacteremia. E. Renal arteriovenous fistula are a recognized (144). 93. A. Brodal bloodless zone lies just anterior to the lateral convex border of the kidney. Percutaneous access to the urinary tract is used to relieve urinary tract obstruction and also allows the urologists to perform endourological procedures, e.g., stone removal, which is less invasive and associated with fewer complications than open surgery. The renal artery divides into the ventral and dorsal branches, which creates a zone of relative avascularity between the divisions known as the brodal bloodless line of incision, which lies just posterior to the lateral convex border of the kidney. A lower pole posterior calyx access via a subcostal approach is usually best for simple urinary drainage. A posterior calyx of the upper or middle collecting system offers the easiest access to the pelviureteric junction for potential ureteral negotiation. Tubes with self-retaining properties should always be used to lessen the risk of inadvertent dislodgement. Tubes of 8. 10 F are usually sufficient for drainage of non-infected urine. Larger tubes, 12. 14 F, may be necessary for drainage of infected urine, or to ensure appropriate urine flow in procedures complicated by gross hematuria. Formal nephrostography should be delayed for 48 hours following tube placement in case of infected urine to reduce the chance of bacteremia. Chapter 6. Test Paper 3, Answers. 168. Transient hematuria occurs in all patients post-nephrostomy. Hydrothorax and pneumothorax can also occur particularly with supracostal entries. Renal arteriovenous fistula, pseudoaneurysm, or vessel laceration are recognized vascular complications during nephrostomy. Dyer RB, ETAL percutaneous nephrostomy with extensions of the technique, step by step. Radiographics. 2002, 22, 350325. 94. A. Primary CNS lymphoma toxoplasmosis. Recognized complication. 94. A 43-year-old man with a known diagnosis of AIDS presents with headache, personality change and seizure. Unenhanced CT brain shows a 5 cm, slightly hyperdense lesion in the right frontal lobe with significant peritumoral edema with little mass effect. Contrast-enhanced MRI brain shows an irregular ring-enhancing lesion in the corresponding location in a sea of edema. What is your diagnosis? A. Primary CNS lymphoma. B. Systemic NHLC, PMLD, toxoplasmosis. E. CMV encephalitis. Toxoplasmosis typically manifests on CT scans and MRIs as nodular small encephalitis and / or ring-enhancing, large abscess, lesions within the brain parenchyma. The enhancing ring, when present, may be somewhat thicker and more ill-defined than that seen in association with a typical bacterial abscess. The lesions are associated with surrounding edema and tend to be multiple at presentation. However, a significant percentage of patients present with solitary lesions. Toxoplasmic lesions are most often seen in the basal ganglia and cerebral hemispheres. On non-enhanced T1 weighted MR images, the lesions are of low signal intensity. On T2 weighted MR images, the lesions are mildly to moderately hyperintense in relation to the brain parenchyma and can be difficult to separate from the surrounding edema. The presence of small hemorrhages may be a sign of toxoplasmosis, and calcifications can occasionally be seen in treated lesions. On CT scans and MR images, lymphoma most commonly manifests as an enhancing, space-occupying mass with surrounding edema. However, much of the time the lesions undergo central necrosis and present as ring-enhancing masses. On non-contrast enhanced T1 weighted images, typical lesions are isointense in relation to brain parenchyma, whereas on T2 weighted images the lesions are isointense to hyperintense. On non-enhanced CT, a small percentage of the lesions are of increased attenuation with respect to the brain parenchyma, as is commonly observed in cases of primary CNS lymphoma in patients who do not have AIDS. The imaging characteristics of lymphoma and toxoplasmosis overlap to such a significant degree that it is nearly impossible to differentiate the lesions on the basis of their appearance on CT scans or MR images alone. Patients with a few solid lesions or ring-enhancing subependymal or periventricular lesions, particularly those with subependymal extension, tend to have lymphomas, whereas patients with multiple ring-enhancing lesions, particularly those that are hemorrhagic in the basal ganglia and cerebral hemispheres are more likely to have toxoplasmosis. Wallet et al. Neuroimaging findings in patients with AIDS. ClinInfect DIS 1996. Encephalitis. 95. A 5-year-old girl presents with left-sided abdominal pain. On examination, there is a palpable mass in the left flank. CT demonstrates a well-circumscribed multiseptate cystic renal mass replacing the lower pole of the left kidney. The intervening septae are thick and enhanced post-contrast, and the cysts appear to be herniating into the renal pelvis. What is the most likely diagnosis? A. Multicystic dysplastic kidney. B. Multilocular cystic nephroma. C. Nephroblastoma. D. Polycystic kidney disease. E. Mesoblastic nephroma. 1996, 22, 690619. 95. B. Multilocular cystic nephroma. Multilocular cystic nephroma is a benign renal tumor that occurs in children and, less commonly, adult women. There is no known association with Wilms tumor. It is usually a unilateral abnormality that replaces an entire renal pole and presents as a large mass, often around 8-10 cm in diameter. Radiological appearances, while not entirely specific, can help to differentiate this lesion from other renal mass lesions. A sharply well-circumscribed, multiseptate cystic mass is typical with a thick surrounding capsule. The cysts appear to herniate into the renal pelvis, an appearance that is relatively specific for mesoblastic nephroma. Unsurprisingly, these lesions are excised, as definitive radiological differentiation from malignancy is often not possible. Multilocular cystic nephroma can be differentiated from multicystic dysplastic kidney by the presence of normal functioning renal parenchyma and symmetrical renal excretion. Polycystic kidney disease involves the entire kidney, unlike multilocular cystic nephroma, which tends to be localized around a renal pole. Multicystic dysplastic kidney is the most common cystic renal disease affecting infants and is twice as common in boys. It is a common cause for abdominal masses in this age group and typically involves one kidney. There are strong associations with a range of genitourinary. Chapter 6. Test Paper 3, Answers. 169. Abnormalities, including vesicoureteric reflux, horseshoe kidney, and ureteric anomalies. The classical ultrasound features are as described above, with near-total replacement of the normal renal parenchyma by cysts of varying size and shape. The presence of thin septations can help to differentiate this condition from multilocular cystic nephroma, in which thick septations are typical. Wilms tumor typically presents in children of 3-4 years of age. Dannert W., Radiology Review Manual, 6th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2007:937-8. Chapter 5. Test Paper 3, Questions. 135. 96. CXR shows a large mass in the right lower lobe. Staging CT shows it to be 8 cm invading the right mediastinal pleura, with ipsilateral mediastinal and subcarinal nodes. There is also a contralateral 3 cm mass in the left upper lobe. This would be staged A, T3N2M1AB, T4N2M1AC, T3N3M1BD, T4N3M1BE, T3N2M1B. 97. 8. 96. A, T3N2M1A primary tumor, T, TX, no tumor found on bronchoscopy or imaging. TIS, carcinoma in situ. T1, tumor size equal to or less than 3 cm not involving the main bronchus. T1A, smaller than 2 cm in longest dimension. T1B, larger than 2 cm but smaller than or equal to 3 cm. T2, tumor size more than 3 cm but less than / equal to 7 cm or involving the main bronchus but greater than 2 cm from carina, or visceral pleural involvement or lobar atelectasis extending to the hilum, but not collapse of the entire lung. T2A, larger than 3 cm but smaller than 5 cm. T2B, larger than 5 cm but smaller than 7 cm. T3, tumor size larger than 7 cm or 2 cm from carina, but not involving trachea or carina, or involvement of the chest wall, including Pankos tumor, diaphragm, phrenic nerve, mediastinal pleura, or parietal pericardium, or separate tumor nodule S in the same lobe or atelectasis or post-obstructive pneumonitis of entire lung. T4, any size tumor with involvement of the trachea, esophagus, recurrent laryngeal nerve vertebra. Great vessels or heart or separate tumor nodules in the same lung, but not in the same lobe. Nodal status N, NX, regional nodes cannot be assessed. N0, no regional nodal metastases. N1, ipsilateral peribronchial, hilar or intrapulmonary nodes, including direct invasion. N2, ipsilateral mediastinal or subcarinal nodes. N3, contralateral nodal involvement, ipsilateral or contralateral scalene or supraclavicular nodal involvement. Distant metastasis, M, MX, distant metastases cannot be assessed. M0, no distant metastases. M1, distant metastases present. M1A, presence of a malignant pleural or pericardial effusion, pleural dissemination, or pericardial disease, and metastasis in opposite lung. M1B, extrathoracic metastases. American Joint Committee on Cancer. Lung Cancer Staging, 7th ed. New York, New York, Springer, 2010. '97, a 74-year-old man with orthopnoea, ankle swelling and paroxysmal nocturnal dyspnea, has had US to evaluate right upper quadrant pain. The scan shows hepatomegaly with a coarse liver. He subsequently has CT of the liver. All of the following are CT findings of hepatic congestion secondary to congestive heart failure, except A, late enhancement of the IVC and central hepatic veins. B, heterogeneous mottled mosaic pattern of enhancement on the portal phase. C, hepatomegaly and ascites may be present. D, dilated hepatic veins. E, periportal edema. 98, a 56-year-old man undergoes US of the 2010. 97. A. Late enhancement of the IVC and central hepatic veins. Passive congestion occurs with the stasis of blood within liver parenchyma as a result of impaired hepatic venous drainage secondary to cardiac disease. Elevated central venous pressure is directly transmitted from the right atrium to the hepatic veins. Passive hepatic congestion may occur with congestive heart failure, constrictive pericarditis, pericardial effusion, cardiomyopathy, or right-sided valvular disease involving the tricuspid or pulmonary valve. Chapter 6. Test Paper 3, Answers. 170. Symptoms of congestive heart failure mask gastrointestinal symptoms. Patients may present with asymptomatic elevation of liver enzymes, jaundice, right upper quadrant pain, hepatomegaly, and increased abdominal girth. In the arterial phase, there is early enhancement of a dilated IVC and central hepatic veins because of the reflux of contrast material from the right atrium into the IVC. Parenchymal phase images show a heterogeneous, modeled mosaic pattern of enhancement, with linear and curvilinear areas of poor enhancement due to delayed enhancement of small and medium-sized hepatic veins. There may be peripheral large patchy areas of poor delayed enhancement due to stagnant flow within the periphery of the liver. Perivascular lymphedemia may be seen as linear low attenuation regions encircling the intrahepatic IVC, or portal veins, and should not be confused with venous thrombosis. Hepatomegaly and ascites may be present. Chest images may show cardiomegaly, congestive heart failure and pericardial and pleural effusion. Torby M. CT of non-neoplastic hepatic vascular and perfusion disorders. Radiographics. 2008, 28, 1967. Scrotum to investigate painless swelling of both testes. He does not recall any previous trauma, and has been systemically well apart from chronic anemia, for which he is being investigated by the hematologists. US reveals bilateral solid testicular masses. What is the most likely diagnosis? A. Metastases from renal cell carcinoma. B. Leukemia. C. Seminoma. D. Fractures. E. Lymphoma. 99. 1967-82. 98. E. Lymphoma can occur in the testis in one of three ways, as the primary site, as the initial manifestation of occult disease, or as the site of recurrence. It is the most common bilateral tumor, and the epididymis and spermatic cord are commonly involved. The sonographic appearance of testicular lymphoma is variable and indistinguishable from that of germ cell tumors. Testicular lymphoma generally appears as discrete hypoechoic lesions, which may completely infiltrate the testicle. Primary leukemia of the testis is rare. However, the testis is a common site of leukemia recurrence in children. Seminoma is the most common pure germ cell tumor but affects unilateral testis. Metastases are rare but are reported most commonly in cases of primary prostate and lung cancer. Testicular fracture usually appears as a linear hypoechoic band extending across the testicular parenchyma. Woodward P.J., ETAL. From the archives of the AFIP, Tumors and Tumor-like Lesions. 99. A 23-year-old woman with multiple skin lesions. Lesions presents to the ophthalmologist with worsening of vision. MRI brain and orbits reveal a thickened enhancing right optic nerve with further focal areas of T2W hyperintensities in the brainstem and basal ganglia. What is the diagnosis? A. NF2 optic tract meningioma. B. TS optic neuritis. C. MS optic neuritis. D. NF1 optic glioma. E. VHL optic hemangioblastoma. 100. A 7. Lesions of the testis, radiologic pathologic correlation. Radiographics. 2002, 22, 1189-16. 99. D. NF1 optic glioma. NF1 is also called peripheral neurofibromatosis, or von Recklinghausen disease. The classic triad includes cutaneous lesions, skeletal abnormalities, and mental deficiency. CNS lesions include optic pathway glioma, thickened enhancing optic nerve, cerebral gliomas, hydrocephalus due to aqueduct stenosis, vascular dysplasia including moyamoya disease, cranial nerve neurofibromas or craniofacial plexiform neurofibromatosis, CNS hamartomas, unidentified bright objects on T2, weighted MRI, and vacuolar/spongiotic myelopathy. Spinal lesions include cord neurofibroma or neurofibroma of peripheral nerves. Optic nerve meningioma, seen as ring enhancement in cross-section, would be suggestive of NF2 or central neurofibromatosis, classically associated with bilateral vestibular/acoustic schwannomas and ependymomas. Optic neuritis would also show nerve swelling, high signal on T2, and enhancement. Post-contrast on T1, weighted FS images, however, enlargement of the nerve on imaging may not be as pronounced as in glioma, and MS is not associated with skin lesions. Note that tuberous sclerosis can cause skin lesions, but is associated with optic nerve hamartoma rather than glioma, or optic neuritis. Dannert W., Radiology Review Manual, 7th ed. Philadelphia, PA. 17-year-old man presents with new onset back and loin pain. A low-dose CT KUB reveals a sclerotic lesion in the lamina of one of the thoracic vertebrae. Which one of the following statements concerning osteoid osteomas of the spine is true? A. They can cause painful scoliosis. B. Involvement of the lumbar vertebrae is atypical. C. Lesions of more than 2 cm in diameter are more common on presentation. D. The nidus within the lesion is osteosclerotic. E. They rarely enhance on MRI after intravenous administration of contrast material. 101. A 50-year-old woman recently returned. 100. A. They can cause painful scoliosis. When osteoid osteomas occur in the spine, they typically involve the posterior elements of lumbar vertebrae and are less than 2 cm in diameter. A painful scoliosis is a common presentation. The nidus within the lesion is osteolytic. Both the nidus and soft tissue components enhance on MRI after intravenous administration of contrast material. Dannert W., Radiology Review Manual, 6th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2007. Returned from holiday complaining of fever and malaise. CXR showed bilateral non-segmental bronchopneumonic pattern. CT showed multiple small nodules in the lungs with enlarged mediastinal and hilar nodes, which show popcorn calcification. What is the most likely diagnosis? A. Histoplasmosis. B. Tuberculosis. Chapter 5. Test Paper 3, Questions. 136. C. Lymphoma. D. Legionnaire's disease. E. Blastomycosis. 136-7. 101. A. Histoplasmosis. Histoplasmosis is only seen frequently in North America. Radiograph may reveal multiple poorly defined nodules in the acute phase. Segmental or lobar pneumonia is less common. Chronic histoplasmosis resembles post-primary TB, with upper lobe cavitation, calcification and fibrosis. Hilar and mediastinal nodes show calcification. Occasionally a solitary well-defined nodule may form, a so-called histoplasma. When the center of this lesion calcifies, it forms a target lesion, which is very specific. In some cases, fibrosing mediastinitis can develop and lead to constriction of mediastinal structures, including airways, SVC, and pulmonary arteries and veins. Adam A. E. T. A. L. Granger and Allison's Diagnostic Radiology, a textbook of medical imaging, 5th ed. New York, Churchill Livingstone, 2008:27980. 102. B. Scurvy. Scurvy is – 102. A 7-month-old baby is seen at the general pediatric clinic with failure to thrive and irritability. Few clinical signs are present on examination, although the child cries on manipulation of his lower limbs. A plain radiograph of the left leg was performed a few weeks ago for a suspected fracture, but no acute bony injury was identified. The doctor reviews this radiograph again. It shows generalized osteopenia of the distal femur and proximal tibia and fibula. A sclerotic rim surrounds the distal femoral epiphysis, which itself is abnormally lucent. A bony spur can be seen arising from the distal femoral metaphysis. What is the most likely diagnosis? A. Hypoparathyroidism. B. Scurvy. C. Rickets. D. Hypothyroidism. E. Hypophosphatasia. 100. Is a dietary deficiency of vitamin C. It typically affects babies from 6 to 9 months, and is characterized by nonspecific symptoms of irritability, lower limb tenderness and reluctance to move legs normally. Bleeding gums can also occur. The condition usually manifests at the distal femur and proximal and distal ends of the tibia and fibula, and it can also affect the upper limb bones and the ribs. There are several key radiographic findings. Bony spurs arising from the metaphysis of long bones are eponymously termed Pelkin spurs. Wimberger line refers to the appearance of a sclerotic line running around the perimeter of the epiphyses, which reflects osteopenic change. Ground glass osteoporosis and cortical thinning are also recognized findings. In contrast, rickets manifests as cupping and fraying of the metaphyses, periosteal reaction, bowing of the long bones and widening of the growth plates. Hypophosphatasia is often indistinguishable from rickets on imaging. Hypothyroidism in infancy also results in osteopenia, with fragmentation of the epiphyses. Dannert W., Radiology Review Manual, 6th ed. Philadelphia, Pa, Lippincott Williams and Wilkins, 2. 103, a 37-year-old man has recently returned from a holiday and has been feeling unwell. Blood tests carried out by the GP show raised inflammatory markers and abnormal liver function test results. A provisional diagnosis of viral hepatitis is made. All of the following are Mr. features of acute hepatitis, except A. Heterogeneous liver enhancement. B. Irregular outline to liver with caudate lobe hypertrophy. C. Extrahepatic findings in patients with severe acute hepatitis include gallbladder wall thickening due to edema, and infrequently, ascites. D. Involved areas may be normal or demonstrate decreased signal intensity on T1W images, and increased signal intensity on T2W images. E. Periportal edema appears as high signal intensity areas on T2W images. 2007:160. 103, B. Irregular outline to liver with caudate lobe. Lobe hypertrophy. In acute viral hepatitis, the major histologic findings are necrosis of random isolated liver cells or small cell clusters, diffuse liver cell injury, reactive changes in Kupffer cells and sinusoidal lining cells, and an inflammatory infiltrate in portal tracts, and evidence of hepatocytic regeneration during the recovery phase. Confluent necrosis may lead to bridging necrosis connecting portal, central or portal to central regions of adjacent lobules, signifying a more severe form of acute hepatitis. The imaging features of acute hepatitis are nonspecific, and the diagnosis is usually based on serologic, virologic, and clinical findings. Probably the most important role of radiology in patients with suspected hepatitis is to help rule out other diseases that produce similar clinical and biochemical abnormalities, such as extrahepatic cholestasis, diffuse metastatic disease, and cirrhosis. At U.S. in acute hepatitis, the liver is often enlarged and may demonstrate a diffuse decrease in parenchymal echogenicity, which causes a relative increase in the echogenicity of the portal vein wall's starry night pattern. A normal liver echotexture does not exclude the diagnosis of acute hepatitis. At CT and MR imaging, findings in acute viral hepatitis are nonspecific and include hepatomegaly and periportal edema. At CT, heterogeneous enhancement and well-defined. Chapter 6. Test Paper 3, Answers. 172. Regions of low attenuation may be present. At MR imaging, periportal edema appears as high signal intensity areas on T2 weighted images. Involved areas may be normal or demonstrate decreased signal intensity on T1 weighted images and increased signal intensity on T2 weighted images. Extrahepatic findings in patients with severe acute hepatitis include gallbladder wall thickening due to edema and infrequently ascites. Images. 104, a 26-year-old man presents to his GP with progressive swelling of the right hemiscrotum, pain, and sick sensation, following an impact during a recent cricket match played 4 days ago. Which of the following statements regarding scrotal trauma is incorrect? A. The tunica albuginea is intact in testicular fracture. B. The tunica albuginea is disrupted in testicular rupture. C. Intratesticular hematomas can be multifocal. D. Testicular fracture requires urgent surgical exploration. E. Epididymal injuries are generally associated with testicular injury. Mortelli K.J. The infected liver, radiologic pathologic correlation. Radiographics. 2004, 20/93755. 104, D. Testicular fracture requires urgent surgical exploration. Testicular fracture usually appears as a linear hypoechoic band extending across the testicular parenchyma. The contour remains smooth and the shape of the testicle is maintained. The tunica albuginea is intact. An associated hematocele or testicular hematoma may be seen. The fracture line may not be visible if filled with isoechoic hematoma. Testicular fractures are treated conservatively if normal flow is identified in the surrounding testicular parenchyma. In testicular rupture there is discontinuity of the echogenic tunica albuginea, with hemorrhage and extrusion of testicular contents into the scrotal sac. This is an indication for emergency scrotal exploration to salvage the testis. US shows poorly defined testicular margins and heterogeneous echotexture, with areas of hemorrhage or infarction. Intratesticular hematomas are usually focal and fairly well defined and may be multiple. They are usually hyperechoic in the acute phase or hypoechoic as the hemorrhage evolves and lack vascularity. Isolated epididymal injuries are not very common, and these are usually associated with testicular injuries. Contusion or traumatic epididymitis appears as an enlarged and heterogeneous epididymis on US with increased vascularity, sometimes associated with hematocele. The appearance is indistinguishable from infective epididymitis. Hydrocele or scrotal hematoma can occur in isolation or be associated with other injuries. Rao MS, Arjun K., Sonography of Scrotal Trauma. Indian J. Radiol Imag. 2012, 22, 42937. 105. Injuries. 105, a 15-year-old. Fifteen-year-old man patient presents with pain on the medial aspect of the right elbow. MRI shows no joint effusion or signal change. The medial collateral ligament is lax, ill-defined, and irregular in appearance. Which of the following is the most likely diagnosis? A. Acute partial ulnar collateral ligament tear. B. Acute partial radial collateral tear. C. Chronic ulnar collateral ligament injury. D. Chronic radial collateral ligament injury. E. Chronic lateral ulnar collateral ligament injury. C. Chronic ulnar collateral ligament injury. Injury to the ulnar collateral ligament, UCL, also known as the medial collateral ligament or medial ulnar collateral ligament, is a common cause of medial elbow pain and valgus instability in athletes. The UCL is made of anterior, transverse and posterior bundles, and is most often injured following acute or recurrent valgus stress of the elbow. MRI may demonstrate increased T2, weighted signal within the ligament, commonly within the anterior band, or hyperintensity within the sublime tubercle. Intra-articular contrast may result in a T sign. When contrast extends in the interval between the sublime tubercle and stripped ligamentous attachment, complete rupture will show extravasation of contrast through the ligamentous defect. Chronic valgus stress, often secondary to throwing or pitching sports, can result in chronic damage to the UCL, with appearances similar to those described, and the UCL often appearing lax, irregular and with poor definition. Plain radiograph findings may include heterotopic new bone formation around the medial epicondyle and local subchondral cysts, sclerosis, and osteophyte formation. The differential diagnosis includes medial epicondylitis and a sublime tubercle fracture. Lateral ulnar collateral ligament forms part of the lateral ligament complex and presents with symptoms of lateral or posterolateral elbow pain/instability. Hackle M, ETAL reliability of 106. A 66-year-old man with a chronic skin condition and progressive painful small joints of the hand has been referred for an X-ray. Plain radiograph reveals extensive arthropathy involving the DIPJs mainly, with some joints showing a penicillin cup deformity. Which one of the following statements regarding the condition is false? A. In 15%-20% of cases, arthropathy precedes the onset of skin rash. B. Involvement of the sacroiliac joints is often bilateral. Chapter 5. Test Paper 3, Questions. 137. C. The severity of the skin rash correlates with the degree of articular abnormalities. D. It affects both synovial and cartilaginous joints. E. Marginal erosions around the joints of the fingers and toes are common. 107. All of the 106. C. The severity of the skin rash correlates with the degree of articular abnormalities. If there is joint space narrowing, signs of inflammation, multiple joint involvement and distal involvement in the hands and feet, with added features of bone proliferation, a seronegative spondyloarthropathy is suggested. Approximately 10%-15% of patients with skin manifestations of psoriasis will develop psoriatic arthritis. Usually such manifestations will precede the development of arthritis. The hallmarks of psoriatic arthritis, similar to those of the other seronegative spondyloarthropathies, are signs of inflammatory arthritis combined with bone proliferation, periosteitis, enthesitis, and a distal joint distribution in the extremities. Involvement of several joints in a single digit, with soft tissue swelling, produces what appears clinically as a sausage digit. The bone proliferation produces an irregular and indistinct appearance to the marginal bone about the involved joint, characterized as A fuzzy appearance or whiskering. Periosteitis may take several forms. It may appear as a thin periosteal layer of new bone adjacent to the cortex, a thick irregular layer, or irregular thickening of the cortex itself. Because of the degree of bone destruction, an involved joint may take the appearance of a pencil and cup, with one end of the joint forming a cup and the other a pencil that projects into this cup. One characteristic feature of psoriatic arthritis in the foot is the ivory phalanx, which classically involves the distal phalanges, especially in the first digit. Sacroiliac joint involvement in psoriatic arthritis is usually bilateral, either symmetric or asymmetric in distribution. The thoracolumbar spine may show large comma-shaped paravertebral ossifications. There is no association between the dermatological extent of psoriasis and the musculoskeletal manifestations. Jacobson J.A. E. Following are features of NF2, except A, bilateral vestibular neuroma B, multiple meningioma C, skeletal dysplasia D, spinal cord ependymoma E, meningiomatoses. 108, a 9-year-old boy on antibiotics. ETAL radiographic evaluation of arthritis, inflammatory conditions. Radiology. 2008, 248, 2378 89. 107, C. Skeletal dysplasia, NF2, or central neurofibromatosis is associated with bilateral acoustic neuromas, sine qua non, schwannoma of other cranial nerves, multiple meningiomas, meningiomatoses, paraspinal neurofibromas and spinal cord ependymomas. Unlike NF1, NF2 is not associated with Lisch nodules, skeletal dysplasia, optic pathway glioma, vascular dysplasia, or mental deficiency. Dannert W., Radiology Review Manual, 7th ed. Philadelphia, PA, Lippincott Williams and Wilkins. Antibiotics from the GP for presumed throat infection presence with abdominal pain. Movement aggravates the pain, and the child prefers to lie with a flexed hip. What is the next investigation to help ascertain the diagnosis? A. Urine test B. Throat swab C. US abdomen D. CT abdomen E. MRI abdomen. 109. A middle-aged Caucasian man presents with hemoptysis. CXR shows multiple round, well-defined pulmonary nodules greater than 5 mm. The most likely cause is A. Rheumatoid nodules B. Wegener's granulomatosis C. Metastasis D. Miliary nodules E. Staphylococcal abscess. 110. Wilkins, 2011:322. 108. C. US abdomen. Be aware of a child who is presumed to have throat or upper respiratory infection, on treatment by GP, who presents with atypical abdominal pain. Younger children cannot describe their symptoms, and up to 1/3 have atypical clinical findings for appendicitis. Lower abdominal pain and flexed leg should raise strong suspicion of a serious pathology. Urine test is abnormal in 30% of acute appendicitis, hence it doesn't help to confirm or refute the diagnosis. CT involves ionization radiation, and MRI is not the primary modality of investigation. US is the primary modality for assessment of the abdomen in children. The most accurate US finding for acute appendicitis is an outer wall diameter greater than 6 mm under compression. Less sensitive and specific US findings for appendicitis include hyperemia within the appendiceal wall on color Doppler images, echogenic inflamed periappendiceal fat, and the presence of an appendicolith. Enlarged, reactive mesenteric lymph nodes may be seen with. Chapter 6. Test Paper 3, Answers. 174. Or without appendicitis. Mesenteric adenitis is a controversial differential of acute appendicitis, and is generally considered as a diagnosis of exclusion. Cogley Jr., ETAL Emergent Pediatric US, What Every Radiologist Should Know. Radiographics. 2012, 32, 365165. 109. 110, a 66-year. 109, C. Metastasis. The causes of multiple macronodules greater than 5 mm include metastasis, the first thing that needs to be excluded unless there is a pre-existent explanation, granuloma, eosinophilic lung disease, eosinophilia, asthma or typical reverse batwing pattern radiograph, abscesses, AVM, history of Osler-Rondeau-Weber disease, Wegener's disease, associated sinus disease, renal dysfunction, rheumatoid lungs, symptoms of connective tissue disease or arthropathy, amyloidosis, chronic Disease, parasites and sarcoidosis, uveitis, parotitis or features of Lofgren syndrome. Dannert W., Radiology Review Manual, 7th ed. Philadelphia. 66-year-old woman with biopsy-proven hepatic cirrhosis is scheduled to have an MRI for further evaluation of her disease status. Which one of the following Mr. features is seen earliest in chronic liver disease? A. Ascites. B. Nodular liver contour. C. Fine reticular pattern of hepatic fibrosis. D. Splenomegaly. E. Esophageal varices. 111. Philadelphia, Pa, Lippincott Williams and Wilkins, 2011:427. 110. B. Nodular liver contour cirrhosis is most commonly caused by chronic hepatitis infection or alcohol abuse, although a number of other diseases causing hepatic injury can lead to cirrhosis. It is pathologically defined by three main characteristics: fibrosis, nodular transformation, and distortion of hepatic architecture. Subtle morphologic changes of the liver may be among the earliest detectable with imaging, including enlargement of the hilar periportal space, enlargement of the major interlobar fissure, and expansion of pericholecystic space or gallbladder fossa. Typically, the anterior segment of the right lobe and medial segment of the left lobe atrophy, whereas the caudate lobe and left lateral segment hypertrophy. The nodular changes in cirrhosis yield characteristic radiologic findings. The nodularity is best seen affecting the liver margin, especially on the left lateral segment. Micronodular cirrhosis, common in alcoholic liver disease, gives rise to a fine cobblestone appearance resulting from nodules typically smaller than 3 mm. A grossly nodular liver margin with 315 mm regenerative nodules is characteristic of macronodular cirrhosis, more commonly associated with viral hepatitis. Other changes in cirrhosis include diffuse heterogeneity of the organ on CT and T1 and T2 weighted MRI. Fibrosis is the predominant cause for hepatic heterogeneity and appears high in signal intensity on T2 weighted MRI. Gupta A.A. 111, a 26-year-old man presence with a lump in the right scrotum, U.S. reveals a 1.5 cm simple cyst in the head of the epididymis. Incidentally, the U.S. also shows multiple non-shadowing echogenic foci in both testes, consistent with testicular microlithiasis. Which one of the following statements regarding testicular microlithiasis? CT and MRI of cirrhosis and its mimics. AJR AMJ Röntgenol. Röntgenol. Microlithiasis is false. A. It usually is an incidental finding on U.S. B. The calcifications develop in the seminiferous tubules. C. It is typically unilateral. D. The calcifications are non-shadowing on U.S. E. It is variably associated with an increased incidence of testicular tumors. 112. Röntgenol. 2004, 183:1595-601. 111. C. It is typically unilateral. Testicular microlithiasis is a relatively uncommon finding in the general population. It is usually an incidental finding, which was initially thought to be innocuous. However, known association include cryptorchidism, infertility, Klinefelter syndrome, Down syndrome, atrophy, alveolar microlithiasis, and most importantly, testicular carcinoma. The prevalence of carcinoma in patients with testicular microlithiasis has been reported to be as high as 40%, and follow-up U.S. was routine. However, recent articles and guidelines do not recommend regular U.S. follow-up. At histopathologic analysis, the microcalcifications appear as laminated concretions within the seminiferous tubules, secondary to defective Leydig cells. On sonograms, microlithiasis appears as punctate, non-shadowing, hyperechoic foci within the usually homogeneous testicle. 5 or more calcifications/image should be present to make the diagnosis. Chapter 6. Test Paper 3, Answers. 175. Typically, they are bilateral, symmetric and scattered throughout the testicle, however, they can be asymmetrically distributed or unilateral. (112) A 17-year-old man with reduced upward gaze on clinical examination reveals a moderate-sized heterogeneous mass in the region of the pineal gland in sagittal MRI of the brain. T1W images reveal areas of fat in the tumor, whereas calcification is best seen on CT. What is the diagnosis? A. Pineoblastoma. B. Pineal teratoma. Chapter 5. Test Paper 3, Questions. 138. C. Pineal cyst. D. Pineal teratocarcinoma. E. Pineocytoma. Woodward P.J., E.T.A.L. From the archives of the AFIP, Tumors and Tumor-like Lesions of the Testis, Radiologic Pathologic Correlation. Radiographics. 2002, 22, 1189-16. 112. B. Pineal teratoma. Pineal teratomas reveal a multiloculated, lobulated lesion with foci of fat attenuation, calcification, and cystic regions on CT scan. T1 weighted MR images may show foci of T1 shortening due to fat and variable signal intensity related to calcification. On T2 weighted images, the soft tissue component is ISO to hypointense. The soft tissue component demonstrates enhancement on post-contrast images. Pineocytomas are slow-growing pineal parenchymal neoplasms. At CT they are well demarcated, usually less than 3 cm, and ISO to hyperattenuating. At MR imaging, pineocytomas are well-circumscribed lesions that are hypo to iso-intense on T1 weighted images and hyperintense on T2 weighted images. On post-contrast images, they typically demonstrate avid, homogeneous enhancement. Cystic or partially cystic changes may occur, occasionally making differentiation from a pineal cyst difficult. However, at immediate post-contrast imaging, cystic-appearing pineocytomas demonstrate internal or nodular wall enhancement. Pineoblastomas are highly malignant pineal parenchymal neoplasms. CT reveals a large, typically greater than or equal to 3 cm, lobulated, typically hyperattenuating mass, an appearance that reflects its highly cellular histologic features. Nearly 100% of patients have obstructive hydrocephalus. At MR imaging, pineoblastomas are heterogeneous in appearance, with the solid portion appearing hypo to iso-intense on T1 weighted images and ISO to mildly hyperintense to the cortex on T2 weighted images. Pineoblastomas demonstrate heterogeneous enhancement on post-contrast images. Necrotic regions and hemorrhage may be present. CSF dissemination is a common finding and necessitates imaging of the entire craniospinal axis. 90% of patients with pineal germinomas are less than 20 years old. CT demonstrates a sharply circumscribed, hyperattenuating mass that engulfs the pineal calcifications. Hydrocephalus may be present. MR imaging typically reveals a solid mass that may have cystic components. Germinomas are ISO to hyperintense to gray matter on T1 and T2 weighted images and demonstrate avid, homogeneous enhancement on post-contrast images. Smith et al. From the archives of the AFIP, lesions of the pineal region, radiologic pathologic pineocytoma. 113. A man with previous episodes of PE presents with acute shortness of breath and chest pain. Recurrent PE is suspected. On CTPA, which is the most common finding of chronic PE. A. Complete occlusion of a vessel. B. Acute angle between the thrombus and the vessel wall. C. Right ventricular dilatation. D. Contrast flowing in an apparently thickened vessel wall. E. Polo-Mint sign. Correlation. Radiographics. 2010, 37 2001 20. 113. D. Contrast flowing in an apparently thickened vessel wall. Direct signs of chronic PE include complete occlusion with decrease in the diameter of the vessel distal to the complete obstruction, intimal irregularities, as broad-based, smooth, margined abnormalities that create obtuse angles with the vessel wall, and intraluminal bands or webs. Indirect signs of chronic PE include post-stenotic dilatation, tortuous vessels, enlargement of the main pulmonary artery, enlarged bronchial artery, and differential perfusion of lung parenchyma, mosaic pattern. The Polo-Mint sign of acute PE refers to the well-defined central thrombus, which is completely surrounded by contrast material. Whitram C. et al. Acute and chronic pulmonary emboli, angiography CT correlation. AMJ Rentgenol. 2006, 186, S4219. 114. D. Echocardiography and blood culture children with turbulent blood flow through the heart, or where prosthetic material has been inserted following surgery. Surgery for PDA, VSD. Sign. 114. A 12-year-old girl presents to her GP with mild fever persistent over a month, myalgia, arthralgia, headache, and night sweats. On examination, the GP notes tender nodules in the finger. Blood test shows raised WCC, raised ESR, and raised CRP. What is the primary investigation to confirm the diagnosis? A. Chest X-ray and blood culture. B. CT of the chest and blood culture. C. MRI of the heart and blood culture. D. Echocardiography and blood culture. E. US of the neck and blood culture. 115. VSD, coarctation, and so on are at particular risk of acute and subacute forms of infective endocarditis. Chapter 6. Test paper 3, answers. 176. In the early stage, symptoms are mild. Children can present with prolonged fever over months accompanied by nonspecific symptoms like malaise, myalgia, arthralgia, headache, weight loss, night sweats, or an acute episode of fever. Tender nodules in finger suggest Osler's node. Clubbing, retinal hemorrhage, raw spots, nail bed hemorrhage, and splenomegaly could be other features of infective endocarditis. Blood culture and echocardiography to demonstrate vegetations is the main modality of investigation. Although MRI and CT would show vegetations, they are not the primary modality for investigation. Tasker RC, ETAL 115, a 65-year-old man with known alcoholic liver cirrhosis presents to casualty with an acute episode of GI bleed. This is managed medically, and a CT is requested to assess for complications of cirrhosis. Which of the following statements regarding cirrhosis-associated hepatocellular nodules is false? A. Regenerative nodules are premalignant. B. Accurate characterization of cirrhosis-associated nodules may be difficult even on histology. C. Features such as size and vascularity on imaging may help in characterization. D. MRI is better than contrast CT for characterizing cirrhotic nodules. E. Regenerative nodules are benign. 100 AL Handbook of Pediatrics. Oxford University Press, 2008. 115. A. Regenerative nodules are premalignant. Cirrhotic livers are characterized by advanced fibrosis and the formation of hepatocellular nodules, which are classified histologically as either 1. Regenerative lesions, e.g., regenerative nodules, lobar or segmental hyperplasia, focal nodular hyperplasia, or 2. Dysplastic or neoplastic lesions, e.g., dysplastic foci and nodules, hepatocellular carcinomas. The differentiation of these lesions is important because regenerative nodules are benign, whereas dysplastic and neoplastic nodules are premalignant and malignant, respectively. However, their accurate characterization may be difficult even at histopathologic analysis. Comparing the clinical and pathologic findings with radiologic imaging features may facilitate differential diagnosis. In particular, nodule size, vascularity, hepatocellular function, and Kupffer cell density assessed at MRI are suggestive of the correct diagnosis. MRI is more useful than CT for such assessments because it provides better soft tissue contrast and a more nuanced depiction of different tissue properties. Moreover, a wider variety of contrast agents is available for use in MR imaging. Familiarity with the MR imaging characteristics of cirrhosis-associated hepatocellular nodules is therefore important for optimal diagnosis and management of cirrhotic disease. Hannah RF, ETAL hepatocellular 116, a 16-year-old presents to the A&E department with an acutely painful testicle and is evaluated for possible torsion. U.S. reveals swollen right testes with reduced vascularity on Doppler imaging. What degree of torsion of the spermatic cord is needed to completely occlude the testicular artery? A. 120B. B. 240C, 480D, 600E, 7. 720. 117. Hepatocellular nodules, correlation of histopathologic and MR imaging features. Radiographics. 2008, 28:74769. 116. E. 720 testicular torsion causes venous engorgement that results in edema, hemorrhage and subsequent arterial compromise. The degree of torsion ranges from 180 to 720 degrees. Experimental studies indicate that 720-degree torsion is required to completely occlude the testicular artery. When torsion is 180 degrees or less, diminished blood flow is seen. A nearly 100% salvage rate exists within first 6 hours after onset of symptoms, which drops to 20% within 12-24 hours. Buttervoli P. Leffler S. Minor emergencies, 3rd ed. (117) A 27-year-old man presents with back pain. Anteroposterior pelvis radiograph shows bilateral symmetric bone erosions, sclerosis, and widening of the sacroiliac joints. All of the following are expected radiographic findings, except A. Bilateral hip joint involvement, B. Vertebral anterosuperior corner osteitis, C. Discovertebral erosions, D. Large flowing osteophytes, E. Fusion of facet joints. 118. A 43-year-old woman on bromocriptine for pituitary adenoma presents to the A&E department with severe Ed. Philadelphia, Pa. Elsevier Saunders, 3015. Dogra vs. ETAL sonography of the scrotum. Radiology. 2003, 227, 11836. 117. D. Large flowing osteophyte sacroiliac involvement is typically bilateral and symmetric, and it usually precedes spinal involvement in ankylosing spondylitis. Initially, there is indistinctness and discontinuity of the thin white subchondral bone plate about the sacroiliac joints. These changes can progress to gross bone erosions. Early erosions of the subchondral bone are often best seen in the inferior aspect of the joints. Along with the bone erosions, the adjacent bone is often sclerotic and joint space narrowing and bone fusion eventually occur. The differential diagnosis of bilateral sacroiliac joint erosions includes inflammatory bowel disease and hyperparathyroidism. However, in hyperparathyroidism, sacroiliac joint space widening is more dramatic. Early radiographic findings are erosions at the anterior margins of the vertebral body at the discovertebral junction. These focal areas of osteitis become increasingly sclerotic, a finding termed the shiny corner sign. More extensive discovertebral erosions may also occur. Anderson lesion. Chapter 6. Test paper 3, answers. 177. Associated bone proliferation leads to a squared appearance of the vertebral body. Thin and slender syndesmophytes are generally evident, representing ossification of the outer layer of the annulus fibrosus. The differential diagnosis for bone production at the vertebral margins includes diffuse idiopathic skeletal hyperostosis, or DISH, although this latter condition more commonly reveals a flowing and undulating appearance. As the syndesmophytes thicken and become continuous, the term bamboo spine is used on anteroposterior lumbar spine radiographs. Facet joint inflammation leads to indistinctness and narrowing of the involved joint, and bone fusion of the joints appears later. Ossification of the posterior interspinous ligaments produces a dense radiopaque line, designated the dagger sign, on anteroposterior radiographs of the lumbar spine. The combination of the fused facets and ossification of the interspinous ligaments produces the trolley track sign. Disc calcification may also occur. Other peripheral joints can be involved in ankylosing spondylitis. Hip involvement is usually bilateral in distribution. Jacobson J.A., ETAL radiographic evaluation of arthritis, inflammatory condition. Severe headache, stiff neck, visual symptoms and obtundation. CT shows increased. Chapter 5. Test paper 3, questions. 139. Density in the cella, but it is not diagnostic. MRI of the brain shows significant enlargement of the pituitary, with high signal on T1W images. What is the diagnosis? A. Pituitary adenoma. B. Pituitary carcinoma. C. Pituitary apoplexy. D. Conversion of micro to macroadenoma. E. Metastasis involving the pituitary gland. 119. Conditions. Radiology. 2008, 248, 2378, 89. 118. C. Pituitary apoplexy. Pituitary apoplexy is a severe and potentially fatal medical condition characterized by the variable association of headache, vomiting, visual impairment, ophthalmoplegia, altered mental state, and panhypopituitarism. The syndrome is often related to hemorrhagic infarction of the pituitary gland, usually in a condition of a pre-existing macroadenoma. CT typically a heterogeneously hyperdense, hemorrhagic components, intracellular lesion, with significant increase in size in comparison to previous imaging. MRI shows a similar finding, with the appearance of blood varying on T1 weighted and T2 weighted images, based on the interval between hemorrhage and imaging. In the subacute phase, 721 days, methemoglobin shortens the T1 relaxation time, and the hemorrhage will appear hyperintense on T1 weighted images as well as on T2 weighted images. In the chronic phase, greater than 21 days, macrophages digest the clot, and the presence of hemosiderin and ferritin causes a strong hypointensity on both T1 weighted and T2 weighted images. Images. Boelis A. 119. A 4-year-old boy is brought to the A&E department following a motor vehicle accident in which he was a restrained backseat passenger. He is in respiratory distress with circulatory collapse. Chest X-ray demonstrates lack of definition of the left hemidiaphragm with multiple cystic appearing structures projected over the left hemithorax. What is the most likely diagnosis? A. Morgani hernia. B. Traumatic diaphragmatic rupture. C. Aspiration pneumonia. D. Bachdalic hernia. E. Congenital lobar emphysema. A. Pituitary apoplexy. An update on clinical and imaging features. Insights imaging. Imaging. 2014, 5, 67, 53, 762. 119. B. Traumatic diaphragmatic rupture. The presenting features include respiratory distress, tracheal deviation, and dullness to percussion on one side. Motor vehicle accidents are the cause of traumatic diaphragm rupture in 90% of cases, with falls from height and a kick to the abdomen or object falling on the abdomen as alternative etiologies. The initial chest X-ray is abnormal in 40%-90% of cases. It may show irregularity or obscuring of the leaf of the diaphragm, fractured ribs, mediastinal shift, intrapleural fluid, or detectable viscera within the thorax. The most important radiological sign is incomplete visualization of the entire diaphragm. Kadish H.A. Thoracic trauma. In Fleischer G.R., Ludwig S.eds Textbook of Pediatric Emergency Medicine, 6th ed. Philadelphia, Pa, Lippincott Williams and Wilkins, 2010. 2010:1471. Emphysema. 120. The differential diagnosis for diseases affecting the bowel in pediatric patients can be narrowed by paying attention to specific radiologic signs and the patient's clinical history. Which of the following findings are incorrectly matched to the underlying pathology? A. Hyperattenuating wall is seen with hemorrhage. B. The halo sign is seen in graft versus host disease. C. The accordion sign is classic in Crohn's disease. D. The comb sign suggests active inflammation. E. The toothpaste sign is seen in chronic bowel disease. Chapter 5. Test paper 3, questions. 1471. 120. C. The accordion sign is classic in Crohn's disease. Several patterns of wall attenuation have been described in association with specific diseases. A hyperattenuating wall is seen with hemorrhage as a result of trauma, purpura, or vasculitis. A submucosal fatty halo has been described as a result of chronic inflammation, such as an inflammatory bowel disease and GVHD. Submucosal edema is definitive evidence of a bowel wall injury, typically acute, often producing the target sign. The accordion sign is caused by contrast material trapped between thickened edema 2 Hausstrahl folds in the colon. Although the accordion sign is most commonly seen in Chapter 6. Test paper 3, answers. 178. Pseudomembranous colitis, it is not pathognomonic. The comb sign represents hypervascular engorged vasorectal lined like the teeth of a comb on the mesenteric site of the bowel. This finding is classically seen in inflammatory bowel disease, especially Crohn's disease, and suggests a clinically active disease. The comb sign can also be seen in vasculitis and purpura. The toothpaste or lead pipe sign has been associated with chronic diseases leading to a featureless bowel. It is commonly seen with Crohn's disease or chronic GVHD, or as the sequela of radiation therapy. D. Almeida M. ETAL bowel wall thickening in children, CT findings. Radiographics. 2008, 28, 372746. Chapter 6. Test paper 3, answers.